Hello, I'm Josh Grew, a researcher at the think tank Living and Dying Well, which provides research and analysis surrounding the end of life debate. And this is the first of a series of short interviews on the topic of assisted dying. Today, I'm delighted to be joined by Dr. Harvey Chochinov, a distinguished professor of psychiatry at the University of Manitoba, former chair of the external panel on options for a legislative response to Carter v. Canada, and a long-time researcher and clinician who has published extensively on psychological matters pertaining to palliative care. It's great to have you, Dr. Chochinov.
Thanks, good to be here.
So to begin, how might psychiatric practice be changed, if at all, by an assisted dying law? And how do you see those changes? Of course, it's been legal in Canada for a couple of years now, so maybe you might reflect also on your experience there.
Great. Well, first off, the data that we're seeing coming out of Health Canada indicates that psychiatrists are asked to be involved in about 5% of instances of MAID. So the reality is that relatively few patients who are receiving MAID are also being seen by psychiatrists. My understanding is they're often asked to play is around issues related to capacity. Is somebody able to give valid, informed consent, and also to rule out psychiatric illness, such as most significantly depression. So that is the role that psychiatrists thus far are being asked to play with respect to MAID. Now, the way that that's changing psychiatric practice, or perhaps will change psychiatric practice, is that, in fact, their response to patients who are requesting or wanting to die is essentially very narrowly defined. That is, are they depressed? Can they give capacity? As opposed to the more traditional role of psychiatry when it comes to patients who want to die, whether within or outside the context of palliative care. And that is to, try and drill down to find out why is it that somebody no longer wants to go on living, and to try and be involved in a way that is therapeutic. So, really kind of fundamental to good palliative care, ongoing commitment, a commitment to non-abandonment, and trying to be present to address the ongoing suffering of patients who feel they no longer want to be alive.
Interesting. Yeah, you mentioned informed consent and capacity to consent. A key question on this topic has been around that and around being able to give consent to an assisted death. In your view, is it possible to determine someone's mental capacity and consent when it comes to an assisted death, given the significance of that decision? And what are the challenges in trying to identify that?
Well, for me, I think, the biggest issue is, how narrowly we define the role of the psychiatrist or the mental health clinician. If you define it very narrowly in terms of consent, does somebody have the capacity to understand what's being offered? Do they understand the alternatives that are available? Do they understand the implications of the choices they're about to make? If you define it in a very, very narrow way, then in a very formulaic approach, you can say, well, this is not a difficult task. I feel that the task is much more complex when you consider the entirety of what psychiatrists should and ought to be doing in the context of evaluating consent and in the context of evaluating people who no longer want to be here. You mentioned in the introduction, for example, that I was the chair of the external panel on legislative options in the Carter decision. And as part of that activity, we visited the Benelux countries, and I spoke to psychiatrists there who were involved in euthanasia decisions. And I'll always remember, the psychiatrist that I spoke to said his task was to understand why somebody wanted to be dead, why somebody no longer wanted to be alive. And until he had a firm understanding about the dynamics of that decision, then the role of the psychiatrist was incomplete. So again, going back to your question, I think if we define the role of the psychiatrist in a very, very narrow way, We might say, well, that's not a difficult task to accomplish. But I think if we take on the entirety of the role that psychiatrists ought to be engaging in, then it becomes a much more complex and nuanced and important task that is not only diagnostic, but as well ought to be therapeutic.
So on that, from 2023, it will be legal to request MAID in Canada for mental illness. What are your thoughts on that? And do you have any kind of stories or advice or anything to say that might encourage someone seeking an assisted death to seek alternative support? I mean, you mentioned the role of psychiatry being therapeutic as well as diagnostic, and how would that come into the scenario that will be playing out in Canada in a couple of years' time, and the implications for what any law might be here in the UK?
Yeah, MAID for mental illness is something that I, along with many colleagues, are very, very concerned about. I mean, the reality is that, one of the symptoms of mental illness is oftentimes the undermining of a wish to go on living. And making a differentiation between suicidal ideation in the context of mental illness versus an expressed wish to die in the context of a MAID request, I think is really going to be impossible for psychiatrists to tease out. I know that I've spoken to MAID providers who have said, they really don't know if they're going to be able to continue in this kind of work, given that suddenly, MAID is no longer about hastening the death of somebody who is actively dying, but in fact, hastening the death of somebody who could have, the potential for many years, if not decades of life ahead. You ask for stories, and the reality is that, every psychiatrist with any kind of experience working with people who are grappling with ongoing suffering marked by, an undermining of their wish to go on living, have experienced people who for years, with their support, have managed to sustain themselves while they're trying to find either cure or mitigation of their symptoms until they can regain some sense of meaning and purpose. And I can recall, years ago, looking after a woman who suffered from a chronic, serious depression. This is a woman who had multiple courses of electroconvulsive therapy. I provided her with every form of treatment for depression that I possibly could. Certainly, one of the key elements of sustaining her through all of that, during which she certainly no longer wanted to be alive, was this ongoing, unwavering commitment to our continuing to work together. And then eventually, there was a new drug that came on the market. I decided I would try her on it. And within a few weeks, I remember her walking into my office saying, life feels different. And I said, well, how can you tell? She said, well, the door is purple. Well, the door had always been purple. It was the same office we'd met in for years. She said, yes, but now I care. And there are umpteen stories of that kind. The reality is that, mental illness is a difficult chronic condition that many people grapple with. And the way that we psychiatrists deal with that is by an unequivocal commitment, non-abandonment, maintaining hope to the extent that we can. And oftentimes it's the power of the therapeutic relationship that is able to sustain people through, those difficult and dark days.
Well, thank you for that. And finally, and moving on slightly, research has suggested that every year more than 1 million older people are abused in the UK. And 39% of those cases from 2017 to 2019 were economic and financial. Other research by Hourglass found that family members and care workers were the more frequent economic abuse perpetrators. We know that other forms of coercion and abuse can exist and be relational, and there are stories of medical coercion in other specialties. Are there possible and practicable safeguards to prevent coercion and abuse when it comes to assisted dying?
Well, one of the realities of the legislation in Canada is that families, patients are not obligated, nor are healthcare providers obligated to notify family members if people are considering death hastening measures. And so if we're going to look at, external coercion, and we can leave, kind of the internal forces that drive people towards making these choices, like, feeling a burden to their family members and so on. But if we just look at external forces, like the influence of family members or others that might be pushing somebody towards making a decision that may not be in their best interest, the truth is, in Canada, there is no obligation, and in fact, we are not allowed to inform family members if patients say they do not wish them to be informed. So how can we make an evaluation of coercion, or at least try and understand the family dynamics that might be pushing somebody towards making a selection of MAID in the absence of being able to inform family members? I was speaking to a colleague recently who said, she had an instance where the family was notified of MAID at the time when they were requested to come and claim the body. Up until then, they had no notion that their family member was considering an assisted death. And I think, when it comes to providing care, we have a duty to care not only towards our patients, but towards family members as well. In palliative care, it's the family that is the focus of care. And if we're not even obliged to notify, to prepare family members, think about the psychological, the trauma that this is inducing on family members who then are having to, pick up the pieces of their lives in trying to move forward. If we, for example, were caring for a patient and the patient said to us, look, after my death, I'd like you to tell my family member that they were a disappointment to me, that, the best thing about dying is that I won't have to deal with them any further. As a healthcare provider, you'd say, look, that's above my pay scale. If that, I am not going to be party to that kind of trauma. On the other hand, when it comes to assisted death, patients can say, look, I don't want them to even know. I don't want them to be told. And we have no legal obligation to notify family members. I realize that there are all kinds of complex families and difficult dynamics that we have to deal with. But again, going back to my experience on that external panel, when I was speaking to my Benelux colleagues, they said, patients are entitled to refuse having family involved, but he as a clinician feels no obligation to proceed with euthanasia or assisted dying until he has a very good sense that he has collected appropriate and meaningful collateral information. So again, a long-winded response to the issue regarding coercion and the kind of external forces that might push somebody or move somebody towards that decision. But again, in Canada, we don't even have that obligation or that right to notify families when these decisions are being considered.
Thank you so much, Dr. Chochinov, for some really interesting thoughts that you've shared. Do watch out for the next interview in the series. And in the meantime, head to the Living and Dying Well website at livinganddyingwell.org.uk to find more research and information. And thank you very much for listening.